Mendoza. We have the Chief Medical Officer from Strong and Highland Hospitals, Dr. Michael Apostolakos. We have the Chief Operating Officer from Strong Memorial Hospital, Dr. Kathy Paranello, and we have Chief Medical Officer for Rochester Regional Health, Dr. Robert Mayo. And we'll start with you, Dr. Mendoza.
Thank you, and good afternoon, everybody, and thank you for joining us today for what we hope is a positive announcement to step in the right direction on behalf of our hospitals here in the community. First, I want to begin by again thanking Dr. Mike Apostolakos, Dr. Rob Mayo, and Dr. Kathy Paranello for their partnership throughout all of this pandemic. For the last 3 months, we've been working tirelessly together. I will say that it has been nearly 3 months ago, almost to the day, that we made the very difficult decision together to essentially eliminate visitation to our hospitals. With a few exceptions, for 3 months now, we've gone without visitation to our hospitals. And I can tell you, after having worked in the hospital just last week, I know how hard it is for families, for patients, and for our staff to be operating in this very unusual environment. We know that patients heal better when they have the support of their family. And it has been a very difficult situation all around. And I want to reiterate that it is not lost upon any of us how difficult the situation has been for our families and for our patients. And it's not lost upon any of us the great lengths that our hospital staff have taken to try to find innovative ways for our patients to communicate with their families. And so today I'm pleased to announce that effective Thursday, we will begin the process of allowing limited visitation to our hospitals here in Monroe County. I want to reiterate that this is a limited beginning. It's very important for us to undertake this process very carefully because we know that people in the hospital represent among the sickest among us in our county, and we want to do everything we can to keep them healthy and well. Although the facilities will all be following the general guidance of the New York State Department of Health, each hospital has its own particulars that necessitate each hospital having somewhat of a different approach to allowing visitation in the hospital. So I will let my colleagues on this call detail for you the specifics of how each hospital system will be undertaking the reopening for visitation. I do want to call out that we are still not allowing visitation yet to assisted living facilities or to nursing homes. We know that our nursing home population represents a disproportionately affected population here in Monroe County, with approximately 20% of the cases in Monroe occurring among people in nursing homes and approximately 70% of our fatalities occurring among people who live in nursing homes. And so we want to be especially cautious about how we undertake the reopening of visitation to nursing homes and assisted living facilities. So that is not yet going to be undertaken at this time, but that is certainly something that we have been paying attention to, and we're hopeful that will occur in the near future. But as we monitor reopening the hospitals, I want to make sure to reiterate that as we learn about how to reopen hospitals, it's especially important that we do not let our guard down. We need to continue to use face masks, exercise hand hygiene, make sure that we're maintaining physical distancing whenever possible, and paying attention to our own risk to make sure that we're not unnecessarily putting each other or our loved ones who are in the hospital at unnecessary risk. So at this time, I want to hand it over to Dr. Mike Apostolakos and Dr. Kathy Paranello to talk about the procedures that are undertaken at UR Medicine.
Thank you, Dr. Mendoza. I want to thank you and my colleague, Dr. Mayo, at Rochester Regional, so that we could unify our response and open up visitation together in a unified way, so that all patients in the community will benefit from this. I also want to thank the media for their coverage today. As all of you know, back in March, as COVID-19 cases were rising and hospitals in New York prepared for a surge of patients, we followed the Department of Health guidance and implemented a zero visitation policy throughout our system. As the community knows, this was difficult for the community, but also difficult for us caregivers in our hospitals. It was a difficult adjustment for everyone who recognize the value of support persons to patients, and we certainly do that. We've been working, last week the state issued updated guidance on hospital visitation, and we welcome the opportunity to reintroduce visitation. The state, we've been working to prepare documentation to submit to the state since then, as required, and to prepare for visitors to return. The state has required hospitals submit their plans for partial reopening 48 hours in advance, and we've done so today. And we expect that Strong Memorial Hospital and Highland Hospital and other UR Medicine hospitals will begin allowing designated visitors into the hospitals this coming Thursday. Some of our hospitals in our system will start next week. Each of our hospitals is different in size, the community it serves, and in physical space. So each hospital's visiting guidelines vary slightly. Families should check each hospital's website for details. We followed State Department of Health guidance in developing these new visitor policies. Our community should note that zero visitation remains effective in emergency departments at Strong and at Highland. And let me repeat that. Our community should note that zero visitation remains in effect for emergency departments at Strong and Highland, which neither have enough space to accommodate larger numbers of visitors and maintain safe physical distancing. Some key points about visitation at Strong and Highland are, number one, the new policy applies to non-COVID patients. Zero visitation remains for COVID patients or for patients under investigation for COVID due to the risk of transmission. Each non-COVID patient can have a total of 2 designated visitors age 18 or older throughout their stay at Strong Memorial Hospital. Highland is allowing 1 designated visitor. Visitors over the age of 70 are discouraged from visiting due to the effects of COVID on the elderly. Only 1 support person can visit per day for a total of 4 consecutive hours. Visiting hours are between 8 a.m. and 8 p.m. for Strong and noon to 8 p.m. for Highland Hospital. Exceptions are in place for oncology, pediatric, obstetrics, diminished capacity, and end-of-life patients. Visitors will be required to undergo COVID-19 screening and temperature check. Any visitor with COVID-19 symptoms or with a fever will not be permitted to visit. Visitors also will receive detailed instructions on visitation rules, proper masking, and hand hygiene to protect their safety, as well as the patients and the caregivers. For surgical procedures, a support person can accompany a patient during the preoperative check-in period and at patient discharge. Support people should plan to be off-site during the surgery. The state requires hospitals to collect visitors' contact information in case contact tracing is required at a later date. Zero visitation contributed to our community's ability to flatten the curve. We thank everyone for their help and ask for their continued support as we reopen this limited visitation. And with that, I'd like to turn it over to my colleague, Dr. Rob Mayo from RHS.
Thank you very much. I'd like to start as well with a word of appreciation to Drs. Mendoza, Apostolakis, and Perinello for the continued and important partnership that we have through this pandemic. Having a shared community approach has been really meaningful because we've asked the community to do the same thing, and we wanted to reflect that as a leadership team through our joint partnership. There are many important commonalities in the approaches to the health systems regarding visitation, and this is reflective of this shared commitment to our community as well as our compliance with the New York State visitation program components. So I would begin by referring all visitors to the Rochester Regional website where these specifics will be clearly explained and listed for you to review. I'll lightly touch on them today as well so that you can hear them and begin to familiarize yourself with them as you revisit these topics at the website. So similar to the UR Medicine approach, we will be restricting visitors throughout our system in part we'll be opening up visitation in other areas so that we can maximize the opportunity for patients and their families to support one another during the difficulties of illness. Our emergency departments at Rochester General Hospital and at Unity Hospital in Monroe County will also not be able to permit visitors because of the confined space and the intense care that is provided there. For patients who are under investigation for potentially COVID illness, and those with diagnosed COVID illness will also not be permitted visitors, but will be given the opportunity to communicate with loved ones through telephone and iPad communications. And during the pandemic, we have enjoyed the opportunity to use video technology to connect families with their loved ones while hospitalized, and we will continue to offer that service and option. Patients who have cognitive disabilities that make them dependent upon guardians or other family caretakers will be permitted visitors, as they have up until now during the pandemic, as well as pediatric patients and obstetric patients during labor. These details, again, are all specified on the website, and I would direct your attention there if you have specific questions. Visitation hours at Rochester Regional facilities will be from 9 a.m. to 1 p.m. in the morning and from 4 to 7 p.m. in the afternoon. So those times, again, will be posted, and encourage you to visit the website to be sure that you can maximize the time that you want to have with your loved one. In closing, I would just like to say that Monroe County as a whole has really benefited from our collective partnership as a community, as institutions, in flattening the curve. It's been challenging, and we have all made sacrifices to achieve this, but we have, it's important to acknowledge that we have achieved a really important flattening in this curve, and COVID, unfortunately, is not going away. And so we will continue to have important restrictions throughout the care experience. These restrictions will be focused on important disease prevention principles, things like social distancing that are so important, protective barriers such as face masks, hand gloves, and personal protective equipment, important hand hygiene strategies. So all these things remain important in our day-to-day lives, and all visitors will be asked to participate in these protective barriers when they are present, and will be screened at the door as they enter. So I want to thank the community for your great participation and collaboration, and look forward to continuing to serve everyone. I'll turn it back to you, Dr. Mendoza.
Thank you. Okay, we're going to open it up for reporter questions with so many people on the panel. If you can, please direct your question to one of the people on the panel. And we're going to get started with Jonathan Hunter from Spectrum.
Yes, good afternoon. Thank you guys for doing the press conference. So this question is for Dr. Michael Apostolakos. You talked about how there was 2 different visitor times between the different hospitals. I think one was like 12 to 8, and the other all had a different time. Was there a specific reason why there were different times, visitation times?
Yeah, each hospital has different staffing patterns and size and specifications, and it was felt at Highland for their for the way they function that limiting it to 12 to 8 allowed them to be able to provide the staff there to do the screening that's necessary and to manage the patient flow and visitor flow. At Strong, we felt that we could extend the hours longer, and part of the reason is we're such a bigger facility that we expect a lot of visitors. We have over 800 patients, and if we limited our hours to restrictive, we thought that it would delay patients' family members from getting in. So it has to do with the size of the facility and the ability of staff to do all the screening that's necessary.
Do you have a follow-up, Jonathan? Take that as a no. Next up, we have Brett Dahlberg from WXXI, followed by Brian Sharp from the Democratic Chronicle.
Hi, all. Thanks for taking this time with us. The first question is for both hospital systems. I just wonder if you can describe describe the balance that you're making. What are you weighing when you're deciding whether and how to allow visitation? And how did you arrive at this balance between whatever the competing interests are that you have to figure out how to match?
Sure, I'd be happy to answer that and then turn the time to Dr. Apostolakis. Well, there are a number of considerations. First and foremost, it is vital that we maintain good epidemiologic preventive measures. So social distancing has been an important part of flattening the curve and will remain so for the future. So not all of our hospital departments have the space to accommodate patients, caretakers, and visitors. So that's one important consideration. Another important consideration is the level of critical illness. Right? Patients who are at end of life have always been permitted visitors. People who have other important care needs that need a visitor or a guardian present will have those visitors as they have had up until now. Those visitors will not be time restricted as the other visitors in the hospital are. So social distancing, the critical needs of the patient are really vital as we make these decisions.
Yeah, I think what comes to play is the risk of COVID versus the risk of not having visitors. We've known, and I've learned over my 30-year career, how valuable patient visitation is by family and loved ones. That patient and family visitation helps patients get better. And we learn from families about patients, visitors and family help them. We initially agreed with the Department of Health that the risk, though, of transmission of COVID initially was greater than the benefit of visitation. Now, how you measure that is very, very difficult. But we knew that we were in a dangerous place with COVID. We were concerned about being overrun with COVID patients, and we were concerned with the transmission. We're the biggest employer in Rochester. We have many patients here, and this would be a prime spot for COVID to pass. However, over a period of time, we've learned with masking, with good hand hygiene, the risk actually in the hospital is much lower, and some would suggest it's lower than in the community. Our antibody tests suggest that. The community's done a great job of masking and social distancing, and therefore the risk of transmission of COVID for the community and for the hospital has reduced. And now we believe that the risk to our patients of not having families visit, not getting the benefit of those visitations is outweighing the risk of COVID. Now, I say that with some trepidation, and once again, hard to measure, but this is why we're not opening up visitation to everyone. We're limiting visitation to one visitor a day to get the benefit, but not open it up tremendously to then increase more the risk of COVID. So it is a balancing act, and depending on what happens with COVID in the community, that risk benefit may need to be readdressed.
Thanks. I want to follow up on some of what Dr. Apostolakis talked about with you, Dr. Mendoza, about the burden of COVID-19 in the community. Back these many months ago in April, you told me there was no model that didn't have us running out of capacity. You said, we will run out of ventilators, there's no question, there's no model we have that has us being able to treat everybody. And so I wonder now, just can you explain like what changed? Now we're starting to open hospitals up for visitors in some limited capacity. What happened?
I'm happy to be wrong about that. The beauty of these models is that the minute you act upon them, they're necessarily going to change. And that's the point. And, you know, based on the data that we had at the time, you know, all of our indications were much more concerning than they are now. But thankfully, the community has rallied. We've done what we thought was unimaginable, unimaginable, and we flattened the curve. And so things have changed. The evidence has changed. And if we had known on March 13th all of the things that we know now, it's likely that we would have taken a different course of action. But the reality is that we didn't. And that's just the art and the science of evidence as it evolves. And we're in a better place now. We're not out of the woods. You know, we're blessed by having a low prevalence rate in this community. But, you know, if that changes, we will have to reevaluate all of this, because at the end of the day, we don't want to put ourselves back in that place where I'm going to have to tell you that there's no model that doesn't have us, you know, not encountering a surge like we had feared back in April and March.
Thank you all.
Thanks, Brett. Next up is Brian Sharp from the Democratic Chronicle, followed by, I assume there's a reporter from 13 WAM will be after Brian.
Thank you, and thank you all for being here today. This question is for Dr. Mayo and Dr. A. I'm wondering if you could address, as far as just go through again, what all people are going to have to expect when they get there, both in testing or checks and masking. I don't know if it's limited masking, but specifically then how that is going to impact for supplies and cost to the hospital to keep up with that additional demand.
When patients come to the hospital, they will enter through one of a few doors that are available for access. There they will be asked several questions about symptoms related to COVID illness or any exposures to COVID-positive individuals or patients. They'll have their temperature checked. If all those things are negative, that they're not indicating that the patient may have early illness, then they will be asked some additional information, some contact information, and then they'll be permitted to go directly to the patients for whom they've been approved to visit. The state program did require that each hospital have an electronic system to record patient visitation. And so we will be recording the names and these individuals and their contact in the medical record of the patient so that we can contact them if for some reason there is an exposure within the facility. So they can expect that, and they will be given instructions on how to wear a mask, and if they do not have a mask, will be given a mask. They'll be expected to wear the mask throughout their stay in the facility. If patients, or if visitors rather, are unwilling to comply with these requirements, then we will ask them to leave. We think that it's important that everyone be compliant with these important rules and regulations for their own safety, for the safety of the loved one that they want to visit, as well as for the other workers and visitors in the facility. And so we will expect everyone to be compliant, and we'll ask them to leave if they're not.
And at Strong, we'll rely on our patients themselves to let us know who their two designated persons are, because we certainly want our patients to be able to let us know who the people are that they want to visit them. And then much like at Rochester Regional, we have restricted access at Strong today too. So there's the only doors the public can come in are doors that are staffed with our guest services personnel. So the main lobby where visitors will present at our information desk, they will have to indicate who they are, show identification, which patient they are wanting to visit. We will note that they are on the list for that patient to visit. They will receive a badge, indicating that they can be in the visit the patient over the next 4 hours. They will be screened. The symptom screening that you heard Dr. Mayo describe will happen. They will have temperature checked. They will be given information about the risks of being in a hospital, being in a public area. They will be masked, and they will be instructed as to how they can safely visit. On the units, we expect that they will be in their loved one's room at all times. We've made arrangements so that if they're in the hospital over a meal time, they can actually order a meal that would come potentially at the same time their loved one meal comes, and they will be able to eat then in the room with their the patient they're visiting. We do, much as Dr. Mayo has described, we will expect that they wear their masks properly. They wear the mask the entire time that they're there. And if they don't follow those instructions, or if they have any symptoms when we do our check or have a fever, they will not be allowed to visit. We're very encouraged, though, as Dr. Apostolakis said. We know there are patients that get better quicker when they have family to visit. Many family members are the people that do take care of patients when they leave the hospital. So we believe patient education will be much easier by having someone in the hospital that's important to that patient to help plan their care in the home.
Do you have a follow-up, Brian?
Yeah, just one. I was wondering, and I tried to search here quickly, so I apologize if I've missed the update. When it comes to nursing homes, as you both run those facilities, I wasn't clear if that's coming in phase 4, or if you could update just on where we're at in allowing family back in to visit in nursing homes.
Yeah, there's been no state guidance on that yet. So the restriction for visitation, as Dr. Mendoza, I think, alluded to in the beginning, is still present in our communities.
Thank you. Do we have a reporter on from 13 WAM?
For taking my call and my questions. And I have a question for Dr. Mendoza today. We've gotten some calls from folks regarding COVID testing results, that they're being delayed a week or so because there's a shortage of reagent. What is the situation with the drive-through testing? And maybe if the other doctors could comment on what the hospital is seeing in terms of COVID testing of patients and staff and how it might be impacted at this time.
Sure. Thanks for your question, Jane. The testing has always been complicated because it varies based on where you get the testing done and where the specimen is sent ultimately to be processed. And throughout the last 4 months, each of our different locations has changed the process based on where the available capacity is. And so currently, the reagent or a liquid that's involved in processing the tests seems to be the constraint in terms of processing time. And so both of our systems and the state and the independent collection facilities have been essentially going to where they can go to get the processing done the quickest. And so that speaks to the challenge. But I will say that in the hospital, it's the fastest. In our primary care clinics, certainly much faster than in the community. And that's rightfully so, because that's where we want people to go to obtain their testing. But I will leave the details to my colleagues. Rob, if you want to start.
Sure. The testing is, it does have some variability for sure. Rochester Regional Health is running on the order of 1,200 or more tests a day. Those tests generally have about a 4-hour turnaround time. Those tests are prioritized for patients, for symptomatic workers, or other urgent, priorities. We are sending out some tests. These are tests for asymptomatic individuals, and those tests to the reference lab can take 3 to 5 days. So those are tests that have a much lower impact on the day-to-day work or decision-making, and so we prioritize that in a way so that the needed areas receive the more rapid turnaround times that are needed to move forward with the decisions at hand.
At UR Medicine, we prefer to do all of our testing in our own laboratory. And so every specimen that's collected at a UR Medicine facility does come to our central laboratory. There was a period of time when we had ample reagent, which is the material that's required to run the test on the instrument. And when we have enough reagent, we have been able to do all the testing that comes to us. There was a period of time a couple of weeks ago where our reagent supply was somewhat short, and we did have to send testing out to some of what we call our reference labs, so outside laboratories that would run the test for us and then send us the results. That takes longer than doing the test within our own facility. Recently, our reagents have stabilized a bit, as well as we've developed a couple of other instruments that can run this test. So one of the solutions to a shortage in reagents was to purchase more instruments, all of which use different reagents. So if we don't get enough reagents for one instrument, we're likely going to have enough reagent for the other instrument. So kind of balancing the instrumentation we use so that we can do as much testing as possible in-house. We've done upwards of 1,600 a day, but then there have been some days where we haven't been able to do as much. And just like Dr. Mayo described, when we're short of testing material, we do have a priority scheme. And inpatients, symptomatic patients, healthcare workers tend to be a priority. Persons needing a test before they can have their surgery or their procedure, they're considered a priority, and we run those internally on the instruments, and we may send other tests out. So it's been a very, I want to say, volatile experience with testing. Not because we, and I know Rochester Regional is the same, not because we don't want to do all the testing, it is because we haven't been able to get from the suppliers all of the reagents we need in any given day.
Thank you for the thoroughness of the answers. I really appreciate that. I do have one follow-up question for Dr. Mendoza. Have there been any new positive cases related to the Dragonfly and the WROC Beer Park situations? And do we know if any of the new cases that we're seeing, new COVID cases that we're seeing in younger populations, can be tied somehow back to the reopening of these bars?
So we have not seen any new cases either to the Dragonfly or to the Rochester Beer Market since last Thursday when we reported them. We are following very closely, of course, with the reopening. And, you know, the challenge, of course, is association doesn't imply causation. So just because a person who has the infection happened to be at a particular location, that doesn't necessarily mean that he or she obtained it at that location, nor does it mean that the person was, you know, could be implicated in spreading it at that location. So there's a balance. And so that's what the contact tracers do. They'll interview the patient, they'll interview the contacts, and we'll make a determination using our usual epidemiology to decide whether it warrants an advisory to the public where we think that there's a substantial risk to the public, anybody who could have been in that facility during those hours or not. You know, it's a balance between trying to make sure that we're responsible both to the business owners who are by and large doing the right thing, as well as to the public who deserves to know when there's a greater risk.
So just a real quick follow-up to that. So we're not necessarily seeing a cause and effect here.
No, I mean, there was a strong enough suggestion at the first two places that we wanted to issue an advisory, but currently there is no reason to suspect that there is a direct link.
Thank you.
Okay, next up we have Jennifer Lukey from WHEC, and Tia Collins from WROC should be standing by.
Hi, Dr. Mayo. The first question for you. I interviewed a family this morning who has a loved one in the ICU at RGH. They have been unable to see her, and they claim that the only information they're getting is when they call and are able to get someone on the phone. So I wonder, and maybe this is a question for both systems, sort of what you've learned through this no visitor policy as far as those interactions with families go, and how you can do a better job or a job, or, you know, I don't want to put words in anyone's mouth, but, you know, just the communication when there isn't someone in front of you to talk to a family member, to understand what's going on with that patient. How do you better communicate with them if they're not allowed to be there?
Well, yes, thank you for that important advocacy. We are encouraging all of our providers and our nurses to be available to families, and they certainly do their utmost. There are times where the intense needs of patients do, you know, require the full focus of the medical team, and it's a tight walk for them too, to set time aside to keep updating families at the frequency that would be ideal. So it's important for families to speak up. Certainly, you know, we have patient relations folks that can lend a listening ear to help, you know, resolve some of the unmet needs if families are feeling that they aren't having the communication support that they would like. But it's important for the community to know that we are fully committed to doing all we can to encourage ideal communication.
Yeah, and I agree. I think we've learned a lot about communication. We've done a lot more video communicating than we ever did. Our nursing staff, our social work staff has done a great job, and our faculty, I should add, of reaching out to patients and patients' families during this time of need. We've done a lot of video conferencing, but I can tell you that this has been difficult. As Dr. Mayo alluded to, the staff has gotten increasingly busy. Remember, things were a little bit slower in the hospital when we were down 200 to 300 beds that were open. As we've gotten busier, the staff have taken on not only the role of the caregiver, but as the family and visitor advocate, and they have to take time to get the video chat set up, to work with the family, and quite frankly, at times they're just so busy they haven't been able to reach out as much. So as much as families and visitors are looking forward to this, we as leadership and as hospital caregivers are looking forward to this, to get the family back where they can visit and help us with the care of their loved one. They want to be there. They want to see their loved ones. As I said earlier, they help patients get better quicker. And so we have learned a lot about communicating, and this will help us when we have patient families that are at a distance. We learn a lot about video chats and how to set them up and how to communicate, and that's been very successful. But I think now we do need our families back to help us as we collaborate with them to care for their loved ones.
Dr. Mendoza, just a quick off-topic question here. Obviously, we're still hearing from families, very hopeful that perhaps graduations can go on in some fashion. What is the latest thought from you on that?
Well, there are no new updates from the governor's office as to changes in that guidance. So I believe it's 150 is the current size that's been permitted. But I do know that the governor's office is looking at this very closely. With phase 4 at the earliest coming later this week, I would be anticipating additional guidance, and I think we're all waiting to see what happens. But I'm hopeful. I think there is a way to conduct these ceremonies safely. But I think the important part is to not get ahead of the governor's office and make sure that we're doing so in a coordinated fashion.
Thanks, guys.
Okay, Atia Collins from WROC, and then Patty Singer from Minority Reporter.
Good afternoon, everybody. Thanks for taking my question. Mine has to do with the timeline. As far as these visitation plans, there are still some limitations. And for you, Dr. Mendoza, what are you looking at going forward to maybe open it up more? Are we going to phase out with less restrictions going forward, or just what are you looking at as far as on the future here?
Well, we're looking at, the entire community as a whole. And, thankfully the numbers are low right now. So if there is going to be a little blip, it ought to be pretty easy to see. We've been looking very closely over the last 2 months now with each of the successive reopening phases, looking to see if there was an impact in phase 1 with phase 2, and then most recently with the restaurants and bars in phase 3. we're looking very closely, we're ramping up our contact tracing even further now that the numbers are smaller. The stakes are even higher. And so we will continue to do that. That's why it's so important that the hospitals are obtaining the information from the visitors, just in case we need to do contact tracing more efficiently. Phase 4 presents probably the greatest risk because the amount of variation in the types of facilities that are on the slate to reopen in phase 4 is more variable to some degree than it has been through phases 1 through 3. So, doing so in a measured, coordinated way will allow us in the health department to follow the data very closely and, make some course corrections if needed, because the last thing we want to do is, set ourselves all the way back to, earlier weeks or phase 1 or 2.
And then a follow-up question, if I can, for either hospital system. I've talked to a lot of families who are, of course, upset about not being able to go to nursing homes and assisted facilities. And you talked about the risks earlier. I'm wondering if you have any words of encouragement, of advice for families who are going through this time who might want to get into those facilities and see their loved ones.
I think what I just offer is that encourage them to use the video chats, be it phone, be it FaceTime, be it iPads. I think contact is important, and because it is not safe yet to have lots of visitors in our nursing homes, I think people shouldn't be hesitant to use maybe communication strategies that they haven't used a lot before and don't think they're as adequate, and they certainly aren't as adequate as face-to-face. But I will tell you, so many of our patients who weren't familiar at all with video chats or using their iPad really did find comfort in communicating that way. So I would just urge families, don't stop communicating because you can't be there in person. Use whatever strategy you can, phone, video, whatever's available to you to keep in touch with your loved ones.
I think that's right. And, for generations, people used pen and paper to write letters. And I know that's not the same as video chat, but it can help fill the gap. And it's a way to communicate love and concern. And there are lots of opportunities to participate in that kind of communication as well.
Thank you.
Abby Singer from Minority Reporter.
Hi. As we get a potential cumulative effect from all these phases of openings, and we know that hospitalizations are the lowest they've been since mid-May, what would be the threshold, though, where you might have to retrench and shut down visitors again? What's the projection for having to back off on the hospital visitation as far as numbers go?
I'll start by first saying that if we see any outbreak in a hospital facility, and the reality is that in spite of all of the best precautions, there are going to be risks that we take, and it's again a balance between the risk of transmission versus the risk of not having visitors. We will follow very closely. We'll do the contact tracing as necessary, and we'll evaluate everything on a case-by-case basis. We certainly don't want to go back to zero. If there are ways to correct things as we go that don't involve anything terribly drastic, that's certainly the way we want to go. But I think at this point, just like everything else in the community, we'll be following the numbers very closely. And if there is a reason to be concerned, we'll evaluate that very closely. And in this case, in very close partnership with our colleagues at the hospital systems, because, as has been mentioned over and over again, the risk of not having visitors is very real. And so we have to balance that risk against the risk of COVID, which currently, thankfully, is quite low.
Yeah, and Patty, we do continue to model what's happening both in the county and in our healthcare system, which, as you know, extends outside the county. And so we do project out for a period of weeks as to, depending on what's happening over the prior week or two, as to what's going to happen. And the other thing that's been great about this collaboration is regularly the county, RHS, and UR Medicine, we talk 3 to 5 times weekly about what's happening, and we put our collective heads together and understand all of our resources, and we'll have an agreement between all of us about what needs to happen. So we're watching this very closely as we're continuing to take care of non-COVID illness. Non-COVID illness now is outstripping COVID illness, but what's going to happen in the future, none of us know.
As a follow-up, there's been numerous questions about nursing homes. What notes are you taking? What are you going to be learning from this slow reopening of the hospitals that you will then apply to the assisted living and nursing home facilities that you operate, as well as some of the other lessons you'll share with some of the other operators in the community?
I think some of the things we'll learn is the appropriateness of making sure we track every visitor and have a limited period of time, the extent to which we limit perhaps where that visitor can go within the facility. You know, in the past, our facilities were pretty wide open. So someone would come to visit, but then they'd also spend time in our gift shop, the cafeteria, etc. And I think it'll be helpful to see how effective we can be in having our visitors stay directly with the patients in their room. I think nursing homes can learn from that too. Keeping visitors maybe out of central dining areas and activity areas, but having them visit in the room. I think also the importance of masking visitors and then using that as an opportunity to educate. Because the education we'll do with visitors isn't only about their behavior while they're in the hospital. Hopefully it will be education about their behavior in their own lives in the community. The importance of continuing to mask, do good hand hygiene, make sure that they maintain physical distance, avoid large crowds. I think that type of education will be really important regardless of where people get that information, be it in the hospital as they attempt to visit or in a nursing home when eventually they'll be able to visit again.
Thank you.
Okay, that's it for our questions. Thank you all for joining us today.
Thank you.
Thank you.
Thank you.